topic on health equity, super important for our communities and individuals. And we've been working on a readmission reduction collaborative for a couple of years. So we did a full intense year last year. There were 10 hospitals participating. And this year we have 6 hospitals participating. We're really building health equity into that focus. And one of the things that I thought was interesting is Colleen here, Angie, what's here? One of the findings in the readmission collaborative last year with some of our tribal partners is looking at patients that were returning for health, heart failure. And there was a large number of patients that weren't even connected with primary care physicians. And that's here in tribal health, where you think all tribal health members have primary health clinic. But I think the number is around 60 patients. So it's like, wow, there's that many patients not connected up with primary care. That was a key finding. So it's really allowed the facility to start looking at other ways to look at equity, access to healthcare within the tribal health system as well. So we have that issue across our state of people not accessing primary care, or is it even accessible? So I look forward to that conversation in more depth.
Great.
Thank you.
And I hope this thing, yeah, it sounds like it's working. Good morning, everybody. It's wonderful to be here in Alaska. We got snow on the ground in April. I grew up in Canada, Montreal, Canada, and this is like kind of a Montreal scenario that, you'd have snow in spring. This is more interesting for me, and I think for all of us, if it's interactive. So just don't even hesitate to interrupt me or ask a question or just stand up and shout something out. I don't care. Because it's boring when you're just sitting there. Because I have no idea whether any of this is resonating with you. And what I'm trying to do today is to sort of just break down health equity a little bit so that you understand what the core ingredients are, because they're kind of universal. It's not rocket science. It's stuff you kind of learn as a young person, really around your family. And how do you apply it to healthcare system design, interactions with communities? That's the tricky part, is trying to figure out how do you take what you know intuitively and apply it kind of at a community level, particularly in a place like Alaska, where you've got such huge distances and some very unique populations. So that's what this conversation is about. And I learn so much more when it's interactive and you tell me sort of what it is that makes sense to you and what doesn't make sense to you. All right, so off we go. So I call this getting underneath health disparities. And it's amazing that we've been talking about health disparities for about 30 years. But we still talk about it kind of in the same way. We talk about health disparities as being basically a product of bad behaviors, bad genes, and inadequate access to healthcare. And that's pretty much how we talk about it. And I want to argue to you that we've got it all wrong. All three of those things are really kind of only slightly true and mostly true at the individual level. They're not true at the community level. And what drives health disparities at the community level is essentially opportunity. It's the ability of people to essentially exercise their God-given skills, talents, gifts, in a society that recognizes them as full human beings. That's what health equity is about. And the problem with our healthcare system is that we've essentially mimicked the rest of our capitalistic system and thought about healthcare as a product that we sell to, really not even to people. We sell to employers, we sell to the government, we sell to insurance companies, but we really don't have a humanistic approach to our healthcare system. And that's the problem. I will tell you one other thing about Alaska is that there are a few models in the world that have caught the attention of basically everybody. And one of them is right here in Alaska, the Nuka model. I'm not going to talk about it in any great depth because I suspect you know more about it than I do. But it's literally a model which is trying to be replicated in places like Scotland and New Zealand and Canada and California and all over the lower 48. So I'm actually going to ask you a little bit about it because I'd like to know more about it because I think it perfectly articulates one of the core aspects of health equity. All right, so what is health equity? There are a number of different definitions bouncing around, and I tend not to be somebody who loves technical definitions because I think that people never remember them and they don't understand them. So health equity is what I told you about before. It's basically facilitating people's access to opportunity in a meaningful way. And in order for people to have access to opportunity in a meaningful way, they have to be able to participate in the processes that essentially dictate how resources are allocated. So those are political processes. They have to be able to participate politically in their communities. And when I say political, everybody gets all tight and worried. I'm not talking about Democrats and Republicans. I'm talking about decision-making that affects things like who gets a park, who gets a grocery store, who gets transportation resources. You know, up here, I don't know what it is. Who gets satellite internet? I have no idea what you all do up here. It's everything's so far away. But it's basically about how do you engage and enlist the participation of people who are most impacted by inequity in deciding how to craft solutions. It's all about participation. Equity is about process. It's not so much about product. But you could use the Robert Wood Johnson definition if you like, which I happen to like, and I'll just read it to you. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness. I'm going to talk a little bit about that in a second. And lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. Okay, well, let's get into this a little bit. So my job when I'm not in places like Alaska is I work at an organization called the California Endowment. And California Endowment is California's largest health foundation, and we're the product of the conversion of Blue Cross of California, which was the state's largest not-for-profit health insurer. They became this thing called WellPoint, which is a for-profit insurer, and they decided they wanted to become for-profit. And in order to do that, they had to put all their assets into a charitable trust, and we're that trust. We have nothing to do with Blue Cross anymore. We're completely independent, and we have $4 billion in the bank, and we've had that for like 25 years. And those $4 billion, we use every year, the interest on it, which is about $200 million. We use to try to improve the health status of all Californians. And I am the chief programmatic person at the California Endowment. So that's what I do. And I'll tell you, it's a lot of fun. I mean, it really is kind of, imagine just getting a blank sheet of paper and $200 million every year to figure out how to try to improve people's health. If we had more time, I would actually ask you, what would you do? But we don't have a lot of time, so I'm going to tell you what we did. And so we spent over the past 10 years, almost $2 billion on this initiative called Building Healthy Communities. And I will tell you, for $2 billion, this is everything that we learned on this slide. That's every single thing we learned for $2 billion in a decade of work. And it boils down to three things. I call it the ABCs. A is for agency. Agency is basically having control over the things that are occurring in your life. And agency matters at the individual level. So each of you need to have agency in order to navigate the challenges you face every single day of the week. But your family needs to have agency and your community needs to have agency. So what we're focused on mostly is collective agency or community level agency. The ability of communities, and disproportionately in the United States, you have communities that have been segregated by race or by ethnicity or by income. So many of the people in those communities are very similarly situated. And it's important that those communities have agency in order to undo the historical forces that have created inequity in their lives. So that's the A. B stands for belonging. And I like to describe belonging as the opposite of racism. It's really the It's the sense that your story is known to others, that you're seen and heard in your full humanity, that you matter, whether you're LGBTQ, whether you're Alaskan Native, whether you're African American, whether you're formerly incarcerated, whether you're an immigrant, that your identity is seen in its whole and cherished and respected. And there are ways of creating belonging. We're doing it in California, which I won't tell you about today, but if anybody wants to know, I can tell you about it. And then the C is very simple. C is basically social determinants of health. It's the conditions of opportunity that we have, or that are resources. I like to think of them as sort of stepping stones. You know, if you are a climber, you think about handholds and footholds. That's what social determinants of health are. They're handholds during the climb. And some people have really good handholds and some people don't. And most of those handholds are policy determined handholds. They're not random. They're things like universal health care or universal childcare or universal paid sick leave. You'll note the use of the term universal. I'm going to get back to that in a second. Okay, so for anybody who's inclined to just tune me out at this point, you've heard everything I'm going to say in a nutshell. So literally, you can go to sleep now. I'm just going to reinforce everything I just said. Okay, so agency, as I mentioned, agency is about, it's about power. Its power is basically the ability to get things done. I mean, it's no more complicated than that. And in life, there are things we need to get done, right? You need to just be able to get some things done. And if you don't have power, it's much harder, if not impossible, to get those things done. And we all know, every one of you knows the patient that's sitting in front of you in a room who's kind of like, you know, shoulders slumped, and you ask them something about their life.
I like that, Dr.
I don't know,
Sheffler.
you know, okay, doc. And you know that that patient is not going to follow just any of the advice that you're giving. They're not going to take their medications. They're not going to be compliant because they have no agency. They're not engaged in the care. And so that's the hardest patient. All
Like I click it, nothing happens.
No, it's basically going to be a huge challenge. Is somebody asking a question or? Okay, all right, well, feel free to ask questions. I like questions. It's the same thing at the community level. Trying to create opportunities for communities to participate in decision-making is critical to creating agency. It's critical to their well-being. No matter what is happening, the ability of people to participate not only improves their health, but you get better outcomes in terms of whatever the problem is you're trying to challenge. All right, so that's agency. As I said, we spent $2 billion doing this. I'm going to give you a case example in a minute. But it's, again, this is the kind of thing you know. You've known it since grade school. You know who the young people are who are going to do well because they have the ability to take on challenges. They have that sort of resiliency. You know, when they get knocked down, they get back up. Well, you can actually teach that. And you can actually stimulate that in community by organizing people and having them come together, identify who the natural leaders are, and then have them lead. Have them lead on issues that matter, whether it be a stop sign in the neighborhood, or I'll tell you an example that yielded $2.2 billion of resources for a very low income community. Agency is something that can be created anywhere, even in very rural communities. Belonging, as I told you, is basically this sense of being seen in your full humanity. And belonging is absolutely critical. I'm not going to give you a case example here because I actually think you know better than I do about belonging because of some of the work that's happened right here in Alaska. And then finally, changing conditions. And this is where it's challenging because we live in the United States of America, which is exceptionally bad when it comes to creating meaningful conditions for people to be able to pursue opportunity. We have a very poor track record. And part of it is because of the way we think about ourselves and the story we tell ourselves about who we are. And that story really is not true, and it needs to change. I want to give you an example of changing conditions because it frustrates me. It's around this time of the year. It happens. You'll see it in the newspaper. Every year in spring, there's a newspaper article. This happened to be this young man in North Philadelphia who got into every single Ivy League school in the country, got into Oxford, and had one of these challenging stories, you know, parents that were low income and struggling. And they all overcame this to be able to create for him the opportunity to excel in school. And it's always a newspaper story, and it always pisses me off. Why? For exactly the reason that he said in this very newspaper article. Don't be happy for me that I overcame these barriers, he says. Be mad as hell that they exist in the first place. This is the difference between beating the odds and changing the odds. And the odds are man-made. And I like to say oftentimes they can be unmade, most often by the work of women. Because women understand the holistic nature of health. And you can't just focus on health care if you care about health. And I can give you example after example. Quite frankly, sorry guys, women are smarter than men when it comes to this. Women see this. There are even studies that show that the percentage of women in national legislatures impacts the quality of health and education legislation and policy. So you want good health education and policy, elect women. I mean, it's virtually guaranteed to have people focus more holistically on the needs of young people and families. Okay, so this young guy says, don't celebrate me, attack the problems that make me such a rarity. And that's what changing conditions means. Okay, so let me just jump into this for the first story. And I'm going to tell it quickly, although there's a ton of slides. And I think I chose this story because it's a rural community. It's from Fresno, California. Fresno is one of the poorest congressional districts in the United States. It's rural, mostly Latino, very conservative governance. From not too far away is Bakersfield, where Kevin McCarthy, who's the Republican Speaker of the House, hails from. California Central Valley is kind of like the southeastern United States, very agricultural and very politically conservative. And so here comes a story from Fresno, and it's about parks. And this is a graphic. Well, you're going to see it later, so I won't tell you what it is. This is a campaign of low-income, mostly undocumented Latino young people in Fresno who recognize that in their neighborhoods, in their communities, when we asked them, we said, what is it that what are the big priorities for you in your community? And the young people said, we have nothing to do in the summers after school. There are no parks. There are no places to skateboard, no places to ride our bikes. If we want to get to these kinds of things, we have to get on the bus or 2 or 3 buses and go to the northern part of town where there is very good park infrastructure. So we worked with them to create this Parks for All campaign. And the disparity in parks is dramatic in Fresno. You see, I don't even have to, you know what I'm talking about. You walk into a community, you look at the park, you're like, holy shizzle. This is a park? I mean, it's just barren with rocks jutting out of it. All the infrastructure is rusted and falling apart. And you're asking kids to play in this. And then you go to the other side of town and you see these dramatic parks with infrastructure and grass and changing rooms and restrooms that are being cleaned and maintained. And you're like, what is going on here? That's Fresno. And so we started this campaign with the Fresno residents, and it was just about finding safe places for kids to play. And when you actually look objectively at Fresno's park concentration, you see in South Fresno, every year, this thing called the Trust for Public Land does a survey of every major American city, including Anchorage, and assesses essentially the park infrastructure. And Fresno for like 5 years in a row came out like on the very bottom of the list. It was like the last number 50 of all of the major cities. And so, and the data was there that the amount of park infrastructure, particularly in South Fresno, was dramatically low. I'm not going to go through the numbers. So young people came together, and I think this is what's critical about this work around agency, is that if you want to make change, and forgive me for saying this in this room, you want younger people than the people that are in this room. Right? You want younger people than me. Young people are rocket fuel for change. Young people don't accept the tired excuses of the institutions and establishment, which we all do because we get kind of worn down over time. Young people are unreasonably demanding of change, which is a really important thing for change. They are rocket fuel for change. So we engaged young people and they told us what they wanted. We actually brought them into these design sessions about what kind of parks would you design? What kind of things would you want to do? They did that in droves. They came out and they designed a skate park. And so we built that skate park. And this is us, the mayor, and some other people dedicating that skate park. We got one of those YouTube skate park guys to come in and help us design it and help us open it. And we did that, not because we thought that this was the way to make change, but we needed to listen to the young people and help them along this journey towards their ultimate goal. And they opened up this skate park. It was great, but it was just one skate park in one big city. And so these young people said, we don't want to stop there. They started going around trying to understand what was happening in Fresno around parks and infrastructure. And they surveyed people, they testified at hearings, they gathered information, they presented that information, and they found the city's general plan. The city's general plan, every city has a general plan. The general plan is like the constitution for that city. It says where the parks are going to go, where the houses are going to go, where the schools, where the commercial is going to go, how the infrastructure is going to be built. And so they found the general plan, and they found in that general plan, in the actual city's general plan, that the ratio of parks per person in the northern part of Fresno, which is much whiter and wealthier, to the southern part was about 5 to 1, or 5 times as many parks per person in North Fresno than South Fresno. And they said, that's crazy. I mean, here it is in the general plan. So they decided, well, let's put that on the side of a city bus. And let's just tell people, that the city's general plan tells the story of discrimination around parks in Fresno. And so they applied to get this bus banner on the side of a city bus. And guess what? The city said, no, you can't use our buses for that. And the answer that they gave was, it's too political. And so the young people are like, it's too political to tell the people of the city what's in the city's general plan. That can't stand. So they got very public about this. They had press conferences. They made this big banner showing the actual data. They got into the newspaper, actually not just even local newspaper, they got into national news on this issue because the city denied young people the opportunity to tell other people what is actually in the city's general plan. Outrageous. Got onto all kinds of news. And ultimately, the city had to acquiesce and gave up and said, okay, you can put up your bus sign. But at this point, the young people said, we don't need it anymore. We got way more advertising on this issue because you said no. And so they decided that they were going to pursue a parks plan. This is a political cartoon with the mayor basically getting excoriated for having denied this opportunity for young people. And this is the mayor basically caving. She's actually come around now and she's a big supporter of this work. But these young people said, this is not enough. We can't just build a skate park. We can't just run up a bus ad. We actually have to change the fundamental status quo. So they started organizing to put an initiative on the ballot in Fresno to raise taxes to fund parks. And they ran into quite a bit of opposition to this. The police chief, the mayor, the fire chief, the police union, the fire union, the taxpayers association, the business association, every single one of those organizations said, hell no. You're not raising taxes in Fresno for those people. So what did the young people do? Anybody want to guess? They what? They got way louder, and they organized, and they got it on the ballot. And then they ran this campaign. Sorry. Let me go back here. They ran this campaign and they got 52% of the vote, which normally would be a win, right? That's more than a majority. Well, guess what? The city and the mayor and the fire chief and the police chief and the taxpayers association did. They sued these young people and said, on a ballot initiative, you need 2/3, which is one interpretation of California law, that you need 2/3 for tax measures. There's another interpretation which says that if the city puts a measure on the ballot, they need 2/3, but if the people put it on the ballot, they only need 50% plus one. So this had to be litigated. So the young people came to us and said, we need lawyers. So we got them lawyers, and they hired a lawyer and they fought this, and they lost at the lower court. They won at the appellate court, and then it went to the California Supreme Court, and they won. And now they're bringing $2.2 billion for parks in Fresno. So the moral of this story is that agency, power, control works. We all know that parks are good for health. I mean, is there anybody here who hasn't made the connection between good parks and recreation and health? No, it's all over the public health literature. Yet we have communities that have very poor park infrastructure. Why? Well, it's because those communities lack political power. They're not viewed as deserving of the full benefits of society. So their needs are neglected, they're shuffled off. And I know you can tell me stories in Alaska. Today, as we sit here, very dramatic stories about communities that lack basic infrastructure, running water, electricity, never mind broadband for internet, all that sort of thing. We know that that kind of infrastructure is critical for people to be able to have opportunity. Those are the handholds and footholds that people need to be able to pursue success in life. Yet we consciously allow some communities to have it and other communities not to have it. And we have to ask ourselves why. Okay, so they won $2.2 billion. Story 2, belonging. It's a very short story. In fact, is there anybody here from NUCA or South Central Foundation? Why is that?
We are an outpatient and we're hospital commercial.
Okay, but don't they have an affiliation with a hospital as well?
They do.
Is there anybody here from there? No? All right. Well, I will tell you again that the model there, and does anybody here not know the story of NUCA? Really? Okay, I'm going to tell you it very quickly as far as I know it, because I feel a little awkward talking to people in Anchorage about something that's in Anchorage that is a national model. So I'll tell you what I know from having been here a couple of times and having learned about it. I actually learned about it from this guy, Don Berwick, who used to be the CMS administrator and ran the IHI, which is basically a Center for Innovation in Healthcare. And the NUCA model was and correct me if I'm wrong, but there was an Indian Health Service hospital that was basically not performing terribly well. And the federal government basically said, look, we'll just give this whole thing over to you and you do whatever you want with it. And they went through basically a human-centered design process, which was focused on sort of the needs of the Alaska Native population. And they created a very different model, which is heavily primary care influenced. And the outcomes are dramatic. They've reduced inpatient hospitalizations, ER utilization, and improved all of the measures of ambulatory care sensitive diagnoses through that system. And it's now, they showcase this around the world. People come from all over the world to their conferences to try to understand how they did this. And what I see when I look at NUCA is belonging. What they did is that they created a system where people saw their own stories, their own identities being reflected in the design. They understood that this system was for them, it was of them. And it's a radically different structure than the typical structure we have in healthcare delivery. And so the reason I didn't want to talk about this is I assumed you guys would know a lot about it. So I'm just I'll read this to you and you can do with it what you want, but I would encourage the group, if you don't know much about NUCA, to learn a little bit about it, because the rest of the world is super excited about it. And it's really kind of cutting edge. So in the NUCA system, strong relationships between primary care teams and patients, known as customer owners, have helped manage chronic diseases, control healthcare costs, and improve the overall wellness of the people we serve. NUCA focuses on understanding each customer owner's unique story, values, and influencers in an effort to engage them in their own care and support long-term behavioral change. I think that what's critical in this is this notion of stories and sort of people's unique identity. And this is Don Berwick. NUCA is probably the leading example of healthcare redesign in the world. US healthcare suffers from high costs and low quality. The system has reversed that. The quality of care is the highest I have seen anywhere in the world, and the costs are highly sustainable. It is extraordinary. It is surely leading healthcare to its new and proper destination. So again, I mean, there's a pretty good model here showcasing health equity. Health equity is about the three things I talked about: agency, belonging, and then changing the odds. I'm going to tell a little story about that quickly. But the NUCA model really does encapsulate this notion of belonging. The institutions have to feel to the users of that institution that they see patients in their wholeness, in their full humanity. And you can't do that with the traditional American capitalistic healthcare system design. You can't, because that model is essentially looking at the patient as a potential profit center, not as a human being. I'm just telling you as it is. That's the problem with our healthcare system, is that we're not actually trying to create health. We're trying to deliver profits, even amongst not-for-profit and religious-based organizations. And that's the problem with health equity in our system. Okay, so I won't spend a lot of time on NUCA, but I will get to story 3 and then conclude. And this is really about conditions. And this is a story that some of you may have heard. I told a little bit of it when I was at the larger conference. And this is about how I grew up. Grew up in Montreal, Canada, as I said. Probably snow on the ground there right now too. It's a beautiful city. It's an old volcano. It's got a lot of great infrastructure: housing, parks, restaurants, public transportation. This is a view from the volcano, looking down on McGill University in the foreground and downtown Montreal in the background, and the St. Lawrence River, which drains the Great Lakes. It's one of the biggest rivers in the world in terms of the amount of volume that it drains. And Canada has a strong social contract. And, they're right next door. So if you don't believe me, just, hop on over there yourself and take a look. It's got universal health care, universal dental care, for children, universal child care, universal paid sick leave. That word universal shows up a lot. And so I'm not asking you to know every policy that every country has in the world, but I am asking you to look for that word when it comes to social contracts. The strength of a social contract can be judged by the presence of the word universal. In order to have universal policies, you have to have social solidarity between groups. You have to feel like you are your brother's keeper to some extent, that your fates are inextricably intertwined. And to the extent that you can do that, you can build the political will to invest in universal policies. Now, I ask you to just reflect for a minute on Alaska. Do you have that political will? And if not, why not? You don't have to answer unless you want to, because that would be fun. But I want you to reflect on it for a second. So I left Canada in the mid-1980s, ended up in Baltimore, Maryland, because somebody told me that Johns Hopkins was the best medical school in the world, and I believed them. And this is what I ran into in Baltimore. And these were conditions I had never seen before in my life. I couldn't understand what I was looking at. I'm still shocked to this day, 30 plus years later, that these conditions persist in East Baltimore. And I asked myself, well, what if I'd grown up in East Baltimore instead of Montreal, Canada? For all intents and purposes, I'm that kid. This kid didn't create that environment any more so than I created the environment that I grew up in Montreal, Canada. Yet this kid has to navigate that environment every single day of his life, just like a young Alaska Native child has to navigate the environments that exist in some of these communities where there's no running water and no electricity and no healthcare and very, very little by way of the kinds of youth development resources that all young people need. So the environments that we create and maintain and then force people to navigate every single day of their lives are, for the most part, not exclusively, but for the most part, within the control of our policymaking apparatus. Yet our policymaking apparatus bestows resources on some communities and withholds them from others. And that is a question that we have to address health equity. And it's not just East Baltimore. This is a place called Scott County, Indiana, that in the year 2015 had the world's highest HIV incidence rate, higher than sub-Saharan Africa. Scott County, Indiana was, at the time, Indiana was governed by Mike Pence, who subsequently became the vice president. The health commissioner was this guy, Jerome Adams, who subsequently became the Surgeon General. And I got invited to Scott County, Indiana to help them to consult on this HIV rate. Again, the world's highest rate. No place in the world had a higher incidence rate of HIV/AIDS. And Scott County, Indiana was in the midst of an IV drug epidemic. This drug called Opana that people were using, grinding up, sharing needles and spreading HIV and hepatitis C very efficiently. And Scott County, Indiana is 98% white. So this wasn't about race or racism. This was about income inequality. And Scott County, Indiana and East Baltimore, Maryland, to me, are essentially the same kind of stress incubator. They're the white and black face of income inequality in the United States. It's a fundamental question about policy. And so the question for me was, what is the American social contract? Anybody want to hazard a guess? No, of course you don't. There isn't one, really. I mean, I don't want to take up too much time here, but I want to make one thing very clear. Social contract does not equal socialism. The Declaration of Independence is a social contract. It explicitly so, designed as the American social contract. A social contract is basically an agreement. It's an agreement between the people who are governed and the government. And what it is basically, we consent to you ruling us, with the caveat that you have to rule in a way that benefits our well-being. And the minute you stop ruling in a way that benefits our well-being, we withdraw our consent to be governed by you. That's, in a nutshell, what the Declaration of Independence says. And it literally lists a list of grievances about King George and says, based on the fact that you have not governed in a way that benefits us, we're withdrawing our consent. And we're going to create our own government, which will govern according to ways that benefit us. That's the whole Declaration of Independence. I encourage you to read it. It's actually kind of a funny read. And so the concept of social contract, and this is comes from continental philosophers, Rousseau and well, all of them really, was explicitly embodied in the Declaration of Independence by the drafters of the Declaration of Independence. So just don't get confused with the word social, just because it says social contract. It's as American as apple pie. In fact, it's more American than apple pie, because apple pie is kind of German. So we have a problem with our social contract in this country. We don't have universal childcare, as many other developed countries do. We don't have universal paid leave, as many other countries do. And we don't have universal healthcare. And these are kind of like the three legs of the stool for civilized societies. And these are the things that you tend to see when women start getting elected into political office. You start to see more emphasis on these fundamental things. And the reason is we lack social solidarity. And when you don't have social solidarity, you don't get universal policies, in a nutshell. The good news is that this can be changed. So I'm going to show you some quick data, which some of you have seen before, hopefully, or maybe not, I don't know. When I got to Baltimore, I got sort of confused. I was like, how is this society organized? It makes no sense. And this question about, when it comes to your health in the United States, does your zip code matter more than your genetic code, became important for me to try to answer. And so I ended up, years later, I became the health officer in Alameda County. This is the San Francisco Bay Area. That's San Francisco that's circled in the red. And that's Alameda County that's outlined in the bright green. And it's a big county. It's about 1.5 million people. And when you're the health officer, you're the registrar of births and deaths. There are about 20,000 births every year, 10,000 deaths, and everyone has a certificate. Every death certificate tells you what the person died of, their age when they died, their race, ethnicity, and where they lived. And I'm a data junkie. I literally dream numbers. And so I was delighted to see this. So we took 400,000 death certificates and we plotted across every neighborhood in Alameda County how long somebody could expect to live. And that created this map that ended up being kind of controversial. I didn't think it would be. I was like, let's look at the data. It was so controversial, in fact, it ended up on the front page of the San Francisco Chronicle. And in those red areas, people can routinely expect to live less than 74 years. In the green areas, greater than 80 years, and the yellow in between 74 and 80. And some of the ones in the red areas, the neighborhoods were like 66 years of average life expectancy. And some of the ones in the green were closer to 90. These are dramatic differences, which, by the way, have gotten worse since we created this map. And it wasn't just Alameda County. We ended up, because people were so shocked by this, having to go around the country and do this with other health departments. This is Baltimore, this is Cleveland, this is New York City, Washington, Seattle, Los Angeles, Minneapolis, Boston, Philadelphia, San Antonio, Denver, Cincinnati, St. Louis, Chicago. Everywhere we looked, we found the same phenomenon. In fact, in the sort of East Coast, South, it was even worse. 30 plus years of life expectancy difference between the same neighborhoods. Now, I say in public health, you don't have to be a rocket scientist, but you do have to be able to spot a pattern every now and then. And, when you see these differences, you cannot explain them based on behaviors. You can't explain them based on access to healthcare, and you can't explain them based on genes. You can explain them based on power, on small p political power, the ability of people to make change in their communities, the ability of people to command needed health protective resources. Explains this entire set of maps. And so when you know that, and I'd love to do it for Alaska, but you're so bloody rural that it's hard to get the numbers. But when you know this, it means that it's now incumbent upon you to do something about it. Understanding that the drivers of poor health are not people's behaviors. Behavior is more of a reflection of the lack of opportunity. And so the goal is to create meaningful opportunity and to create handholds and footholds for people across your entire community. Now, just for any data junkies that might be here, it's a little bit more data. You can take life expectancy and correlate it with poverty, both from the census, and you get this, what we call a social gradient, which is each of those blue dots is a neighborhood in Alameda County. And as you move from left to right, you're moving from relatively wealthy neighborhoods to relatively poor neighborhoods, and you see life gets correspondingly shorter. There's a cost of living in a low-income community in Alameda County, and you can measure it in terms of years of life. It's a death tax. It's the price you pay for living in a poor community in Alameda County. We did the same thing for the entire San Francisco Bay Area and the same thing for the entire state of California. And then we did a whole bunch of counties in California because we could, for the purpose of comparing them to Canada, which was a little quirky thing that I wanted to do. So we looked at Canadian metropolitan areas, did the same analysis, and then aggregated at the top the California counties and the Canadian cities at the bottom, and you see a flatter line in Canada. The cost of living in a poor neighborhood in Canada is much less in terms of length of life than it is in California. And by the way, many other American cities. And there's a reason for that, is that Canada has a social contract. Canada buffers poverty. So if you're poor or live in a poor neighborhood, you still have universal health care, you still have universal childcare, you still have universal paid sick leave, you still have decent libraries and public transportation. You have access to those health protected resources in a more meaningful way. We're doing the same thing for a bunch of European countries. I'll tell you, there'll be the same phenomenon. The United States is unique in its essentially the social cost of poverty. If you're poor, you're screwed across all of the social determinants. I mean, there isn't one that you benefit from. And that's by design. Okay, so let me finish up here with a quick recipe. This is, I went to medical school in the 1980s. God, it was that long ago, wasn't it? Oh my God. And it cost me about $100,000 back. And this is what I learned for $100,000. Basically that risk factors create more disease, which creates earlier death. And the goal in this cascade of despair is essentially during 15-minute interventions in a cubicle to try to somehow use pills to reverse all of that. I'm not even being sarcastic here. That's what I learned for $100,000. And I'll tell you this, it's not entirely wrong. If you ignore everything else, that's what you're left with, is like a 15-minute intervention in a cubicle and a bag of pills, and figuring out which pill for this particular social crisis do I use. And sometimes you can mitigate some of that crisis, not for very long. What we argued is that it's necessary to do the downstream work, but it's woefully insufficient. There are a whole host of upstream opportunities in which we can intervene, most of which are mediated by policy and can be unmade and remade. So if you're concerned about health disparities, they live downstream. If you're concerned about health inequities, they live upstream. You can take the word health out because it really applies to education, it applies to housing, it applies to virtually every human domain. Inequities drive disparities. If you're simple-minded like me, you talk about conditions that create consequences. And we spend a lot of time managing consequences. And you know, that definition of insanity, doing the same thing over and over again and expecting a different result, our system is insane. It is insane. And we're all participants in this lunatic asylum of healthcare where we think we're going to actually solve this problem in 15-minute interventions in a cubicle. So it's on us. We're the crazy ones. We're the lunatics running around thinking that this is going to make a difference. So I argue that these are democratic problems. They're not technocratic problems. And we need to spend more time upstream. We've simplified upstream really about narrative. Narrative is how you create belonging. You tell a different story about us, about who we are, what we value, what we care about. That's what we're doing in California. We're telling a different story about who is a Californian. And it changes, narrative changes policy. Policy is essentially the C, the footholds, the handholds that allow people to do what, with their talents, what they're naturally able to do. And then finally, we talk about place, which is the environment where people who are experiencing these inequities tend to congregate as a result of a legacy of discriminatory policy, and places where you build power, build agency, control, so people can participate. And at the end of the day, that's the recipe. Healthcare costs live downstream, true health lives upstream. I'm gonna stop there. Because I hope somebody's keeping time, because I have no idea what time it is.
We're good, fine. 20 minutes.
Wow, look at that. Okay, good. And I want to open it up to you just for any sorts of insights or thoughts about this. Again, I told you everything that I was going to tell you that first slide. It's all about agency, belonging, and changing those fundamental conditions. And that applies whether you're in a rural clinic in Alaska or a massive metropolitan hospital in Los Angeles. That's fundamentally what underlies health equity. It's the ability of people to participate, to be seen in their whole selves, and to have access to these resources that are handholds and footholds in this, this challenging climb of life, which we all have to contend with. How we translate that into sort of the day-to-day, well, that really depends on the day-to-day. And hopefully we'll have some opportunity in the next part of this session to discuss what that looks like. But I would love to stop talking and start listening a little bit to your experience.
I have a microphone. Anybody have some thoughts?
Nobody else does, I will, to start with. I'm Jeannie Monk with Alaska Hospital and Healthcare Association. I completely agree with everything you're saying, and I think it all makes sense. Where I get stuck is looking around the room at people who work in hospitals and nursing homes around the state, and how do they put this into action? So, particularly when they're mostly, or many of them are with very small facilities who they struggle to do the medical side, to stay staffed and to do that. And as much as people might want to get upstream, they're, and I shouldn't speak for people in the room, but on some days overwhelmed with just trying to meet the actual healthcare needs. So where do we start?
Yeah, great question. And it's a question that we get a lot. So I don't want you to feel intimidated about this. Part of the reason that I try to boil this down is that it is intuitive. It's not some special, thing cooked up in a laboratory by a bunch of pointy-headed scientists. This is something that your grandmother would teach you. And similarly, when you're trying to figure out how to apply this to a setting like a clinical setting, you have to have this basic maxim at heart, which is start where you are. Think about where you are. So what do you have around you? Well, you have patients. You have staff, people who are working on these things. You're in some sort of institution, which is in a place, which literally has neighbors. You've got resources coming into this institution. The institution procures things. You've got also leadership within that institution, which has a voice at some level in policymaking. So you have avenues for applying some of this. The simplest thing that we have helped some institutions work with, and it really depends on how you're situated. We work mostly with FQHC clinics, but also with Kaiser Permanente, which is a big health and hospital system, and Sutter in California, which is a big hospital system, is this idea of starting with the people that are part of your day-to-day enterprise. So you've got patients coming in, so-called patients. I actually don't like the term patients because we're people, people that are whole people. We're not just sort of a set of diseases that, manifest themselves as supplicants in front of a healthcare institution. But anyhow, you've got patients. Patients have wisdom. They have knowledge. And so the paradigm, and many of you are doing this, so I don't even want to imply, this is why I want to hear from you. I don't want to imply that you don't know this or aren't doing this, but this paradigm of sort of like expert doctor, nurse practitioner, and patient who basically is kind of ignorant and passive. And the goal is to sort of disgorge information into the open beak of this patient in this 15-minute encounter is a paradigm that is a tired and essentially paternalistic paradigm. Having patients organize, patients that are similarly situated, to essentially in group visits, for instance, is a very simple intervention that many institutions are using to sort of have similarly situated people help each other and see the sort of the clinical staff as a resource rather than sort of the expert kind of, information disgorger. That's a very simple thing. Another simple thing is staff. You've got staff that come from the community. What are the kind of workforce implications of that staff? Are there career ladders within that institution? Is there training and development of that staff in a way that allows them to move up within that institution so you minimize turnover? I suspect in Alaska, that's probably the case. I suspect you probably do that because you can't afford to lose staff. You just don't have a lot of people, so you got to hang on to them. But this is the kind of thing a lot of institutions are like, oh, okay, yeah, we can do that. That's health equity work. That has benefits to the larger community. Now, there are other things that you can do that we've worked with some large institutions around about, where they procure their resources from. Do they support local businesses? I could go on and on about this, but I really want to hear kind of from you about some of the things that you're doing.
Anybody with some thoughts on your local communities and how you see some of these underlying issues belonging?
Hi, I'm Jamie Eggert. I work at Providence Boston Medical Center. I was previously the director of the emergency departments and a few other areas, now working in quality under Jake's team. And at PNC, just last year, we did an initiative around DEI work and restraint. And what we found is, looking at our data, just happened to find it one day that there was a disparity in the amount of restraint usage in patients that were not Caucasian. And so we did a big project in our emergency department to try to drill down on why. A lot of great crucial conversations with our staff. And one of the big contributing factors we found is Anchorage Police Department, whether you are picked up for a criminal behavior or whether you're homeless on the street, if they're bringing you to a hospital, they put you in handcuffs for the safety of their officers. And so one of the big things that we found is working with APD to really challenge what we do when they come into our hospital system, because it's one of those things that we want our officers to be safe. However, we have to challenge whether they need to be in restraints when they come into the ED. And just that alone, just looking at that, examining that, and working on that, we were able to reduce our restraint usage, overall restraint usage, by a significant amount. And so I think what you showed is that sometimes it's the data that wakes us up and tells us, hey, you got something you got to look at here. And what I found through the entire process is it felt like one more thing instead of a redesign of the actual system. So I really resonate with what you said, that we're working in an insane system and we're just finding these things like, oh, that over there. Oh my gosh, what about that over there? And what I'm looking forward to in the future of healthcare is that we actually redesign the system that make it easier for us as local leaders to do the right thing.
Wow, that was fantastic. That was really fantastic. Thank you. I mean, you just beautifully illustrated what I was trying to say. And I'm sure there are other stories like that. And I think what would be interesting is understanding how people felt, the people that were in restraints, before this intervention and how they felt after. The same people, how they felt their interaction with, their relationship was with your institution. Because at the end of the day, this work is all about human relationships. That's what humanistic healthcare is about. It's about understanding that we're all in relationship. And it's about preserving and building those relationships. That is healing. That's the healing part of health. That's the care part of health. It's not just the clinical, scientific disease moderation strategy. It's so much more than that. And your story just beautifully illustrated that. Thank you.
Trust.
It's trust. Yeah.
Because we had one individual who was restrained multiple times, multiple occurrences. We had this initiative come out, and the nurses that were working with that patient took a questioning attitude when they would have probably just said, oh gosh, it's time for restraints. This patient, we know them very well. We spent 45 minutes with this patient trying to de-escalate and avoided restraints. The next 2 admissions that they came in, no restraints needed. It's trust.
There you go. Thank you.
Hi, I'm Melissa Davis. I'm also with Providence Alaska Medical Center. Just a couple of things. I work in our risk management and patient safety team, and one thing that we're starting to build into our process on the back side when we have sentinel events or serious safety events or even precursor safety events is doing some data gathering on just some of those social determinants of health, forgetting race and age. And, we can even drill down into starting to get, like you said, neighborhoods, zip codes, things like that, where we're really just beginning the journey to say, hey, is a disproportionate amount of a certain population or, group experiencing harm in our facility. So really just beginning that journey. But it's interesting just to think about, Jamie mentioned one more thing. So we're like, okay, we're going to do one more thing. But then after we get that information, how do we then, instead of like tacking it on as an additional thing, how do we then take that opportunity to redesign? And part of that also is we're working to start interviewing our patients when they have these events, really learn from them. And so really just kind of change the whole narrative, but it's definitely a journey, but that's one thing that we're working on. And another thing that I'm not specifically involved in, but that we do as Providence is we have community health workers. And that's a new initiative that started just a couple of years ago. And really it's people from the specific different communities. We have, I think 6 last I knew, but hoping to grow, people who live in those communities and they work in those communities and they take, people to doctor's appointments, or they help them get their groceries, or they do things, and then feeding the information back to the hospital to say, okay, how can we as an organization help all of these different various populations and really improve the overall holistic care. So those are just a couple of things also that we're doing. I think it can feel like this is not enough, but it's something, and we have to start where we are and start to make little changes.
No, that's not nothing. And starting where you are is so critical to being effective. I mean, because you actually have to grow your own muscles in doing this work. You can't just sort of leap to testifying in Congress, day one. You actually have to, kind of like work out a little bit to try and fail and iterate around these things. But what you're describing is huge. It's not small at all. Community health workers, something that my organization has invested in very heavily in California. That's a very large scale intervention because that affects both the community, the institution, the individual, the workers themselves. It changes the administration's perception of what they're trying to do. You're not just trying to sell healthcare anymore. Now you're actually trying to improve health in a community, which is one of the biggest challenges, is getting from that mind shift of like our business is to sort of like sell a product, as opposed to our business is to try to improve the health and well-being of a population. We haven't made that shift in American healthcare. We're being forced to in many ways because the cost of the product is so high that nobody can afford it anymore. So it's kind of like, okay, well, maybe we do have to think about health a little bit. But at the end of the day, we have to make that shift from us as just sort of an industry that is, trying to sort of make a living off of the illness of a population, as opposed to us as a kind of stakeholder and a steward of the health of a community. Now it's a very different business model, and it flies in the face of some of the incentives that exist within the current healthcare delivery system. So thank you for that example. That's a great example. I could ask you why are you investing in community health workers? I mean, it's a cost. It doesn't necessarily improve your bottom line. And I'm not really asking you this question, although if you want to answer it, that would be great. Because it's a reflection of a shift from selling something to trying to manage towards health.
Yeah, I think, part of it is trying to move from being so hospital centric to being more like ambulatory community based, because we really see that's where the need is. It's not just within our four walls of the hospital. It's really how can we help the population be more healthy, and not have to come to the hospital as much.
Yeah, that's great. Holly was telling me a story just earlier about, sort of essentially a mobile nursing program that their hospital told them. I hope you don't mind me telling the story, Howard. They got a grant from HRSA for 4 years to run this out in the community. And the hospital administrators came to them and said, after 4 years, this thing better make money, otherwise we're shutting it down. Again, that mindset of just like, this is a business. This is not about health. This is a business. So this thing has got to make money, is the primary kind of directive to people who are recognizing a need and trying to be innovative and solving it, bringing in healthcare outside the four walls of the institution, and then getting warned that, you're violating the business model of this institution, beware. So that's part of the challenge. That's a huge part of the challenge that we have to address.
Okay, I'm Jennifer. I'm the Chief Nursing Officer from Petersburg Medical Center. I'm down in Southeast. We have a island community of 3,000 people. Our medical center is pretty much the only healthcare, all intents in the community. We have a small 12-bed hospital with a long-term care as well as a family practice clinic. And part of our mission is the promotion of wellness in our community. So we're really working hard to be innovative. And like you said, the problem is it doesn't pay. So, because of our mission, and we try to we're community hospitals, so we really try to listen to our community. So some of the things that we're working on are the school doesn't have funds for a school nurse, so we have a nurse in the schools. We have one of the primary issues for people to come to work in healthcare is childcare. And we heard that loud and clear. It's a community problem, and I know it's a state problem and a national problem. So we actually took on some childcare and have basically a wilderness program. So, so we have all these fantastic things going, and then also really trying to expand the home health agency. And they have expanded beyond basic home health, which is primarily Medicare, but to do all of these community resources. And so we're working really hard at this, but being a very small facility without a revenue stream to reimburse those costs, that's where our struggle is the system of healthcare pays for inpatients. We already have a very low inpatient volume because of our attached primary care. So we have a lot of these strong things going, but financially, we're kind of shooting ourselves in the foot because we're working on the outside outpatient and the community-based services where the inpatient is where it pays. So that's kind of where we are, is we're relying on grants and funding, and so those won't be there forever. So we're really trying to find a way to incorporate these changes in the community, because we know that, working with kids in the schools and wilderness programs and after school programs will help the health of people in the future. But we're doing the best we can, but it's really hard because still have to pay for the infrastructure of the hospital, and just the resources are very limited. So that's where we are, we're working towards trying to fulfill our mission, but it's really difficult and a lot of work to try to put them into practice with funding situations.
Yeah. No, it's another great story. And I could probe a little bit. Don't give it away yet. Because you've made investments in community health in the school nursing and some other things in your primary care. And so you're driven because of your mission to invest in prevention. But you're driven because of your finances to essentially protect your moneymaker, your 12 beds in your hospital. So this is kind of an impossible tension, right? I mean, you're really struggling with this. And this is where policy is absolutely critical. This is where your legislators need to be helping you figure out a reimbursement model or incentive structure that allows you to make those investments in prevention at the same time as maintaining your quote unquote moneymaker, you know, in a realistic way. And so I would argue to you that because you've got a beautiful case study of how the reimbursement system isn't working for your, community, which I would imagine is similar to other communities. This is an opportunity to sort of bring this into the policy sphere, to argue for changes in reimbursement that will allow mission-driven organizations who are doing good work in the community to be able to continue to invest in prevention, improve the health of that community, and ultimately save Alaska and everybody else a lot of money on the downstream end. I would love to take that to, the legislature. Anyhow, that would be my thought. That right there, you've just like encapsulated a beautiful story that should stimulate policymakers to think about how can they better help you do more of what you're doing.
Yeah, it's a work of progress for sure.
All right, well, I don't want to put you on the spot.
I know the CEO, and he has been to Juneau. He is the most outspoken person in the state saying we need to change our payment model. And has not been able to get anybody to kind of help him figure out how to pay us differently.
Well, here's where
But he's working on it. I mean, he's there. He is the most determined person I know in the
he
last.
sounds like he's the right leader for that institution.
We're very happy to have him.
Yeah, well, I hope he's successful because that's exactly what he needs to do.
Hi, I'm Mary Willis, the administrator for long-term care in Kotzebue, Alaska. We are very rural, and one thing, we have 18 beds. One thing that we recognized a couple of years ago is our antipsychotic use, our dementia with behaviors. We have an extremely high number of temporary staff because of our location and education. We have 15 CNA positions, sort of a nursing assistant positions, and we have 2 permanent and 13 travelers.
Wow.
So one thing that we identified was the correlation between an increase in antipsychotics and the behaviors or the standards of those staff that were coming from different places. All of our elders are Native Alaskan, and it's just, they're totally different cultures. So some of the things that we had to do was educate those temporary staff on, when you come here, you're conforming to their culture. They're not conforming to yours. So we saw a significant, when we started doing that dive a little deeper in that education on those staff members, a significant decrease in our antipsychotics. Because was it really a behavior, or was it the reaction to their treatment and how they weren't used to? So I think our temporary staff leave with a lot more knowledge of the culture of Native Alaskan elders, and I'm really proud of that we were able to. And then we have TDYs or temporary staff that return. They're getting some value out of that treatment and respecting that patient-centered care for our elders. So we've made some good strides on reducing the antipsychotics in our facility, and culture change for sure for our staff.
That's another fantastic story, and it's so resonant for me. You see the same thing in school discipline in a number of different settings where you've got, African-American kids, Native American kids, immigrant kids that have these young teachers that are sort of cycling through these systems, and they're just suspending and expelling them because they don't understand the culture, they don't understand the experience, they don't understand the lived reality of these young people. And so they try to impose the culture on them. And one of the strategies that we try to use in some of the schools is to grow our own teachers. And I imagine it's hard for you guys because you have small populations, but workforce investments that can help grow staffing from the community and the culture that is the culture being served is something that I know there's a lot of grant money for that that you should pursue if you're not already. But yeah, that's a great observation. Are you in a position where you can start relying less on these kind of traveling staff, or is that pretty much a feature of your system?
It's kind of been there 7 years, and it's kind of the standard. We may hire a couple, and like I said, we are so rural, so a lot of the younger kids that they're so vocal, they want to get out and they want to experience other things. So we do try to facilitate, and we groom them, and this is what we have to offer, and this is what we can do, and we have really good benefits. Our company is a really good company. So it's very difficult to groom those younger people that are going through those classes. We have one class, I proctor the class, that there's nobody else in for the testing. We just do whatever we can do to facilitate getting people trained and tested. They just often do not stay. So we had to kind of shift a little bit. We still try to recruit, and we want local people, and this is over. And when we have our board meeting, that the board wants to know, why are you not hiring, more local people? It's not because we don't want to, because we absolutely want to. But in the interim, we're still going to work on that. But we have to make sure that these temporary staff members understand you're here in this environment, and this is the behavior, this is how we do things here. And it really is, I worked all over the country, it really is totally different than anywhere else in the United States. Absolutely, totally different. It's a total different subsistence lifestyle, just cultural. We don't make them get up at a certain time. And in the lower 48 hours, everybody's got to be up, you got to eat breakfast, and you get at 7 o'clock, come on, then we got lunch at noon. And it's very structured because they have so many patients to care for. So ours is really absolutely based on what that elder needs at that time. If they, are used to staying up all night, and they stay up all night, and we feed them, So it's very individualized. We hear a lot of facilities say it, especially long-term care facilities over in the United States, it's patient-centered, but is it really? No, it's not really, because I've been in lots of them. In Alaska, I can tell you, it's definitely patient-centered. We serve native foods. There's a lot of things that we do to try to make it more like home for them. But the struggle is real. I think everybody would recognize for staffing, absolutely. And then the people that come in, just the education for them. But it's something that we have to invest in for our elders to be able to care for.
Yeah, no, thank you. That's a fantastic story, and completely aligned with this notion of belonging, creating cultural environments that resonate with the people that live there. So they see their own stories being reflected in the institution and essentially embraced. That is absolutely critical. Thank you for telling that story.
Hi, I'm Jessica Pugh. I work at YKHC. I'm the policy and procedure manager in performance improvement. I can really identify with everything that you said. I think one of our big issues with staffing across the state of Alaska is something that needs to be worked at from a Washington level. I think that the ICWA laws had really good intent when they came into place. I think it's a law that hasn't been re-looked at in a very long time. And I think with some of the constraints with background checks. We're not allowing people from their communities to go into healthcare, to be trained, because we go to hire somebody and they look at their background, and because of a certain thing that they did maybe when they were 18 or 19, they no longer can now be part of taking care of people within their own community. I don't think that's what the law was intended to do. And I think until we go to Washington to make some changes with that law, we're going to continue finding that to be a problem. I know many people out in the Delta that have tried to go to work for different places, but the minute the background check comes back, they're denied. And so we're kind of doing this self-fulfilling prophecy. You know, these are people that are living in these communities, they're born and raised there, and they have families, they have children, but yet they can't get a job and provide for their families and children because of a law that was supposed to protect their family and children. That's just my take.
No, that sounds like a great opportunity to me. And it sounds like you're on it, but to get a waiver, from this law for 5 years and, maybe renewing it and just seeing what difference it can make. I mean, you've got, who's your senators again? Murkowski, yeah, you got Murkowski. Is she not interested in this?
I've gone there.
Yeah, I mean, again, that's,
I guess I won't be working for the next few weeks.
it's,
But I really do think it's an issue.
yeah, and I think you beautifully explained it. I mean, it's very compelling. Why would we want to keep people from these jobs and the well-being of these communities if we have, an opportunity to do something about it? And, tell them it's not going to be a permanent thing. Let's do it on a waiver basis. Let's just see how it works. And you can show the statistics, show that you can hire locally, and then you can get it made permanent. I mean, that seems like very logical policy to me. And this is a Republican state or independent state or whatever. So it's not, you've got some juice on this thing. You'll have Democrats that want to support this.
Hi, I'm Christy Wren. I'm the quality director over at the Alaska Psychiatric Institute. And I think one of the biggest barriers that we face here is there's nowhere for people to go. So I deal with a lot of patients who experience homeless. They either are homeless, they go to the hospital, they're cleared, they come to API for a mental issue. They end up going to DOC, and we get a lot of patients that bounce back and forth from DOC to API to the street. We've been looking at our data probably for the last year now with our governing body about where do these patients go. We look at everywhere that we discharge them to. The same thing, they bounce back and forth. It's also a money issue. You have a lot of ALFs who Medicaid does not reimburse very well. They don't want to take some of these behavior patients. We house patients at API because no one else wants them. We opened up a unit probably about a year ago when we started looking at our data, when we realized most of our issues in restraint and seclusion had to do with our dementia patients, autistic, and those just struggling with behavior. They don't really have a mental illness. But because there's nowhere else to go, we opened up this unit, we moved these patients over there, it decreased our seclusion, restraint, and our assault by 76%.
Wow.
So it was huge for us. We are not an autistic facility. We are not a developmentally delayed facility. We've got resources from the autism community to help do some training, to help our staff better deal with certain types of patients. We have patients that their families don't want them. The villages don't want to deal with their patients coming back to the villages either. So it has to matter to the legislature, and they have to throw money at this problem to help. And for us, mental health is not on the top of the spectrum for a lot of people. It's at the bottom, unfortunately. And I think a lot of states struggle with that. So for us, we're only an 80-bed facility, and we have just now gotten, I think, to 75. We have the same staffing issues as everyone else. Most nurses don't come out of nursing school, want to be psych nurses. They want what I call the sexy nursing. I want to be ICU, flight, trauma, mother, baby, pediatrics. It's rare that people really want to be psych nurses, so we struggle with travelers too. And getting them onboarded and dealing with psych patients. The state of Alaska, just by history, if you don't get travelers by probably February and March for the summer, you're gonna be without travelers and you're gonna be short-staffed, especially when the cruise start. So it does have to matter. And I believe CNN about 8 years ago did a talk about healthcare disparity and that, you know, you can be a cardiologist and see a patient for 15 minutes and you're only reimbursed at $150, but if you go to a cath procedure, you're reimbursed at $1,500. So we have it backwards. And to me, where we start doing primary care is at school age. Money gets invested at school age because as a single parent, if you're a single parent with a mother of two, it's cheaper for you to go to McDonald's and get a full meal than it is for you to go to Cars and, you know, buy for one child a healthy diet. So that disparity has been here for years. And even when CNN did their, I don't know if any of y'all saw that, it was called The Ring of Fire. And they talk about the healthcare disparity. And for us at the psych hospital, we see it a lot in our patients when they will not go and seek treatment somewhere else. They won't do their follow-ups unless they have a care coordinator. Even in our Native population that has access to free healthcare right down the road, it's rare that they will go and get their own follow-up treatment also because of the trust in the community, you know, and it is a vicious cycle. We have patients whose families, they don't know what to do with their mental health loved ones. And the only thing they can do is call APD and have them arrested because at least they know they're safe until they can get an ex parte to get admitted. So it really is about the legislature. It's about money and what's important to this state when it comes to healthcare.
Yeah, no, that's really well said. There are a few things you said that were particularly interesting to me. I have no idea what the cruise ships have to do with this, but I'd be curious about that.
Increase the number of people that come here.
Okay, and that's a bad thing for
Well, the hospitals that are already short-staffed and overburdened, you now have people that come up. Unfortunately, it is a lot of your 70 and 80-year-olds that come up. It's they don't realize how taxing it is to be on a cruise here in Alaska and then get on a bus at 5 a.m. to travel across the state and then get back to their hotel. It wears on people. And so the hospitals get overburdened also, increased inpatients coming from out of state.
Oh, interesting. Thank you for telling me that. Well, I want to say that literally everything you said, we have the same problem in California. I mean, it's literally, maybe not so much with the rural aspect, although we do have some, you know, very rural places. I feel like this is an American problem. I mean, one of the things we do in California is that we tax millionaires. We tax millionaires at special tax just for our behavioral healthcare system at the county level. So there's essentially a millionaire's tax that funds services for severe and persistently mentally ill people. And that it's helped. It's helped in terms of creating the kinds of long-term resources that are necessary to help manage some of that population. What it hasn't helped with are people who don't quite meet that threshold of severe and persistently mentally ill or you know, severe depression. And so you have a lot of people with sort of crises, you know, the emotional crises, young people, and we don't have infrastructure, you know, for those young people at all. So I think this is an American problem. And I think it's absolutely true that there is a stigma to mental health, which makes it vulnerable in the policy setting. It's not sexy like you know, cath lab or you know, or whatever. But to my mind, it argues more for sort of organizing and an aggressive policy approach. I think that we just can't let legislators off the hook on this. We're seeing some movement in California on mental health, which I think is constructive, but it's everything you said literally is happening elsewhere as well. And so it's an American problem that we have to solve. Thank you. And again, I don't know who's keeping time, but I will talk forever or listen forever. So
I think hearing from our communities is super
I agree.
important and very helpful. We had planned for a roundtable for people that are for facilities, get together, kind of do a health equity assessment and then set out in 30, 60, 90 day goals. The forums will be back here and you can do that when you get back home, but let's continue this discussion until we have a break.
That sounds great.
Hi, well, I'm the director of nursing at our long-term care facility here, but this is actually about our school system and the school nurses who, as we talked about these programs, we're seeing many of our students, especially at the very beginning of COVID, when we had them still in school, that weren't coming back. So we were sending them out, we were saying you had 10 days unless you prove it's not COVID, or 14 days at the time, unless you prove it's not COVID. And our parents were like, we don't have time to get off of work and take them. So what they've done in the last 3 years, they now have a program for every student in ASD where we have, they have telehealth. So if you get sick and you go into the school nurse, if your parents agree, you can go through the telehealth program and they do everything where the nurse is doing the assessment with the doc on the phone or on the computer, listening, and then the docs will call in medication for the families, and it's all free. So so they looked at that, they saw that there was a problem, they saw we're not getting students back, students are out for a sore throat for weeks, and they're missing all of this, and one of our pediatric clinics here in Anchorage was very willing to, we'll do this for free. So it's all for free. They gave us the equipment for free. And now if your students say if you can want to take them to your doctor, go for it. But if you don't have a doctor or you don't have the time because you can't get out, here's how they're handling it.
That's a great story. I'll tell you, the educational loss from the pandemic is the worst disparity we've seen in this country in decades, and the lifelong implications of that for low-income families of color in particular, but really kind of all families. We haven't even begun to understand the impact of that. There's a generation of young people who are both psychologically traumatized by, 2.5 years of being outside of the classroom, but have also the learning loss. Just for African-American kids in California, it's 3 years of learning loss. They're 3 years behind where they should have been in terms of their educational attainment. At this rate, they will not catch up. They will not catch up. So that'll be a lifelong deficit. We're not even contending with that in any kind of meaningful way. That horrifies me, because education is the single most important modifiable social determinant of health. If you're going to invest in one thing, and you should never invest in one thing, but if you're going to invest in one thing on social determinants or health equity, education, education, education. That is absolutely the key. So thank you for that story.
Hi, Megan McKenna with Norton Sound Health Corporation. We're based in Nome. So one of the things we've really been working on, and kind of goes with things I've heard other folks saying, while we're working with our patients, we're also working with our employees, because they're also our patients, also our customer owners, particularly our Alaska Native employees. And coming to an understanding when we talk about our patients' cultures, that's also our employees' culture, and things like systems and schedules and how that works is different than the Western model. And we tend to run our clinics on the Western model. We accommodate that for our patients, but are we accommodating that for our employees? So understanding, and the thing I think for me, coming from the outside world, that I had to understand is in traditional Inupiat culture, there's no word for days of the week. So this idea of working Monday to Friday is not just a thing.
Mm.
And so the words for months of the year are not naming the months, they're the seasons to do things. This is the season to pick berries and the season to pick fish. And the day to go fishing is the day that the weather's right and the fish are running.
not the day that you took off work for.
Hmm.
So we are learning to schedule differently and we don't have to bring in travelers maybe all the time, but over scheduling with travelers for those times when our employees would be fairly on subsistence.
Mm.
So if the employee calls in the morning and says, hey, the fish are running, I'm not coming in today, you don't have to fire that employee.
Hmm.
If the employee it doesn't work for their life rhythm to work 8 to 5 or 8 to 8, what schedule are we accommodating for them? And having a lot of different schedule options. And at the time of interview, asking the employee, okay, what subsistence seasons are important to you? What schedule works for you? You know, are you a morning person? Are you an afternoon person? What are your kids doing? What's life like? And then particularly for those Native employees, making a schedule that works for them, kind of partnering them with other employees. Yeah, it's more expensive, it's way more complicated, but it does build us longer term employees. And then dealing with the education, with our community health aides, with our CNAs, with other incoming employees. They're coming out of high school and they can't pass the TAME test, which is the introduction to these healthcare courses. And so rather than saying, well, you know, you can't get in the program, we're hiring, we're onboarding those employees and then putting them through our own training so they can pass that test. Again, expensive, but we can create an employee and maybe they don't stay with us, you know, consistently for a long time, but they will come back and forth and we'll have to over.
Wow, that was so compelling. Oh my God. But have you written this up anywhere? Oh, please do. No, but please do. I think that was the most interesting cultural competence case study I've ever heard in my life. That is incredible. I mean, the whole idea of, you know, first of all, you explain kind of what subsistence is. And this idea of the fish are running and I'm not going to fire you because you got, I mean, wow. I mean, that's incredible. You got to write that up. That's very publishable.
I will say we've implemented it from all levels of our corporation, from our PBS staff up through our vice president. So all of our employees are guaranteed subsistence leave. The other thing I want to highlight that really reaches out again for our patients and our staff that we have been sharing around the state is our healthy foods program. So out in the bush, everything comes by airplane. Food is extremely expensive, and by the time it gets to you, the quality is not so great. And we realized as a hospital, we had this great bulk food purchasing program with Cisco that we could buy food at a reasonable price, and we were already getting it. And why couldn't we sell it to people? And then so we created veggie markets. So we set up a produce market, sell at cost in the hospital. And then for our villages, we do veggie boxes. So we'll make a box of food, send it out. They were trying to work with the local food co-ops, and just by the time the food got to us, the food wasn't any good. So this allowed us to control that. And we incentivize healthcare, visit the dietitian, visit the tobacco educator, and you get veggie bucks that you can redeem for veggie boxes.
Wow.
And that the state of Alaska American Heart Association partnered with us on those projects, and they've been super successful in getting healthy food in the home.
What's the name of your institution again?
Norton Sound?
Yeah, you got to write this up.
Norton Sound Health Corporation, they're also building a daycare.
Yes.
I would give you a grant if you were in California. I would rush money over to you.
This is awesome. So Alaska Native Medical Center is co-managed by South Central Foundation, which you mentioned with the Nukamala,
Right.
and Alaska Native Tribal Health Corporations, which includes Norton Sound,
Okay.
YK, Bristol Bay, Manilek, anybody, Search, South Central Health Foundation. So they're the other part
Okay.
of the consortium for the management for the Alaska Native Hospital
So
here.
I'm seeing where that cultural competency comes from. That is super impressive, but I'm not just flattering you here. That is some of the most impressive stuff I've ever heard. You guys got to push that out somehow. I know you're doing it, and writing it means there's more work, but wow, are there foundations here, health foundations that support you in that effort? Well, are there health
There are
foundations?
some Alaska foundations we might want to tap into and support you with that.
No, I mean, we've worked with AHA, we worked with the State Primary Care Association, and we work with anybody who will work with us. With our regional sister organization, where our social services does our workforce, like vocational rehab and stuff like that. We have a direct entry program from their graduates into our facility.
Well, I might actually give you a grant, because that needs to be shared, particularly the workforce stuff. What you said and the way you described it blows my mind, and that needs to be shared. So I will get in touch with you.
We're gonna be moving into the break, but one thing you mentioned earlier, Anthony, was youth equals rocket fuel. And so as you go back and work on your 30, 60, 90 and your hospital, how do we look outside these four walls? A couple of things to keep in consideration in our communities. In many cases, our hospitals are the primary employer and resource of funding and support for our entire community. Many of you know I'm going back to tribal health starting in May, but one of the conversations that I've been having with Bristol Bay, which is my community, Bristol Bay Native Corporation, as well as Bristol Bay Hospital and Health Corporation, is around youth. How many of our boards have youth boards? How many of our boards have youth providing information and feedback about future? And so when you were talking about youth being rocket fuel, and if you ask our youth, what will it take to create health within our communities? It's going to be a total different answer than the boards that we've got in place right now. So how exciting would it be to see Alaska getting our youth more involved in very compelling roles to help guide the direction of the future? So something to think about.
Yeah, I'll say one thing about youth quickly is if you're going to engage youth, and you should, pay them. You've got to stipend them. You've got to have some mental health resources for them to be able to access, because a lot of these young people are experiencing very high levels of trauma, particularly now, post-pandemic. So it's not just sort of extracting, kind of energy from them, which they're full of. You've got to kind of support them in those efforts, and sometimes it's a lot of support. So it's one of the things that we learned. So there's a responsible way of engaging young people, and there's a less responsible way. Do the responsible way of engaging young people, and they will. It's amazing, because we did building healthy communities for a decade, and the young people that started with us, some of them are now legislators. They learn their leadership through this process, and once you're a leader, you lead. I mean, there's no going back. So it's an incredible investment to not only make, but then to witness the development of these young people and how powerful they become. I mean, it's my church. It is life changing, and so it's the gift that keeps on giving. So do it.
Thanks for those pointers too. Responsible development of our youth. So let's take 15 minutes. Break, and then right about 15, and then we'll move into our next presentation. Thank you, Dr. Iton.
Thank you.